Thank you. Dear Professor Sami and dear Professor Marcus, thank you so much for kind invitations. It's my great honor to join this MASSIN Congress. I learned a lot. I'm Dr. Zhao from the Xuan Hospital and the China INI, and also the Capital Medical University. I'm a functional neurosurgery. So today I'm going to talk about the LITT and RNS in epilepsy surgery. So I will introduce our domestic LITT and RNS is about the clinical trial, the results of the LITT and RNS. So as everyone knows, the epilepsy affects at least 50 million cases of the epilepsy patients worldwide, and 1/3 being a drug-resistant patients. That means the patient take the two kind of the anti-epilepsy drugs cannot control the seizure. So in China, at least we have 1 million DRE patients. So a lot of gap to do. Now, still now, the surgery is the one option for the anti-epilepsy drug patients. So back to 2001, Dr. Weber published the RCT research in the Journal of England Medicine, proves that anterior temporal lobectomy is much more effective for the mesotemporal lobe epilepsy. So now is the gold standard for the temporal lobe epilepsy, but also another option is the selective amygdala hippocampal ectomy, have the same effect is the angle 1 is about 66. But why we are seeking for the minimal invasive ways? So long-term follow-up, we can see the seizure control is the dropping down. Is the going down. It's the about for the 5 years is seizure control is less than 50%. So another concern is about post-operative complications. It's about the visual field defects and also the cognitive disorders. So this paper is the research that even the amygdala hippocampal selected. So for these procedures, it can damage the neocortex. When you open the ventricle and cut the temporal stem, much in the dominant side, the patients maybe have cognitive disorders. So this is the reason why we use the stereo EEG. Thank you, Professor Talalahe and Bancao in France. They developed this technique in 1957, so 70 years past. Now in China and also in the States, they have used the stereo EEG for per-surgical evaluation. And we can, through the stereo EEG to recording and stimulation, and in the meantime, we can make a lesion. So for some selected cases, maybe this RFTC is a minimal invasive treatment methods for some patients. So now many centers publish the results, including the Lyon and Milan and Beijing. Now the 3D radio frequency can reach about 50% of seizure control. So this is our result. We acquired about 76 angle 1. For what reason? We design is called a 3D RFTC. So we wondering if two contacts from the different electrodes can make a lesion together. So I did a vitro and vivo test to prove that coagulation fields merge when the contacts are under the 7 millimeter apart. That makes the double times greater than the traditional methods. So for this test, we designed a special for the mesotemporal lobe electro implantation. One is from the axial, from the occipital to the head of the hippocampal. And in the meantime, with 3 orthogonal electrodes to input the head of hippocampal and the body of hippocampus. So we reached the 1 year follow-up. The angle class is 76 seizure control, and 5 years is about 40%. So now recently we published a paper about the pilot RCT to prove that this 3D FTC technique can significant improvement compared to the ATL. And another minimal invasive is the LITT. We can use the laser canal insert through the stereotactic approach and intraoperative MRI scanning to confirm our lesion is private temperature control. Recently, there's a multi-center study about 234 cases prove that this LITT used for the epilepsy reached outcome is 58%. So the techniques view is the lesion is made priority to the amygdala and the head of hippocampus. And also this position statement was published in the neurosurgery by the American Society for Stereotactic and Functional group. So now in China, we have our domestic Chinese LITT system. We did some clinical trial. This is MRI positive patients, 30 patients, including the hippocampal sclerosis, the benign tumor-induced the seizure, and also the focal cortical dysplasia. The MRI shows the first line is the hippocampus and the focal cortical and the mesotemporal lobar epilepsy. So the outcome is about the 67 in Guoguang. This is a pipeline of a Chinese domestic LITT system. We use the surgical path planning and robot assistant for the laser implanting, and also confirm the LITT, the volume post the surgery. So LITT is not only for the mesotemporal epilepsy, but it can used for the recurrent glioma. So this is our first 32 patients is recurrent glioma. The median survival time is 19 months, and no significant side effect. So I move to the second part about the RNS. First, let's see this case is a female 50-year girl with the right hand knee. The age at the onset is 3 years. So we can see the seizure started from the right up limb with the clonic and tonic seizure. And the ictal EEG showed is the discharge from the FC and the C3. So how about the MRI? We can see there's a focal cortical dysplasia located in the rolantic zone. And the MAG and the PET MRI show this is a epileptogenic zone. But the DTI reconstruction gives us more information. We cannot move or give the resection for this cortical dysplasia because it's, there are some pyramidal fibers penetrate from the lesion. So this time we selected what we selected for the patients, RFTC, LITT, or a weak resection. We worry about, we don't want to hurt the young girl's motor functions. So this time we implanted the RNS system. This is the responsive neurostimulation system. We can see there are 2 electrodes with the 8 contact located in the rolantic zone. It's dramatic. The base seizure frequency is 730 per month. And after the 5 months follow up and 1 year continuous stimulation, the patient's seizure stop. So now let us rethinking about the epileptic network. The lesion is still there, but we used some stimulation, modulation, the network of epilepsy. So what's the mechanism of the RNS? So Penfield did pioneer work for the cortical stimulation and can reduce some seizure happens. I think RNS is the base on this principle. I think RNS system have approved by the FDA in 2013. It's a closed loop devices. We can recording real time and give the stimulation in the same time. So this is maybe the mechanism of RNS. So now we have many stimulation device, the DBS in the thalamus and the VNS. And RNS is a new tool for us to give the closed loop stimulation. So this is a 9-year prospective, effective and the safety about RNS. We can see the median seizure frequency reduction is about 75 at 9-year follow-up. So we did our Chinese RNS system, the first in human study. This is our implantation for the patients, and much more is about the bilateral hippocampus. Is enrolled 6 patients. So the RNS is a seizure stop or not? I think it's not like a cardiac defibrillators. It's just to stimulate continuous the normal EEG can occur some results to control the seizure. The reason is that the RNS is based on the brain network. We must select the analysis, the connectivity, and the location and the state of the network, and also concerned about the plasticity of the epileptic network. So finally, we'll move to the new concept of network neurosurgery. So this paper published that the brain is towards network guide neuromodulation for epilepsy. Now we have a tool about the LITT and RFTC. This is destroyed the seizure onset zone. So it can disconnect the epileptogenic zone and the normal network. And another is the RNS. It can suppress the seizure generation and restore the normal network. So this is a Science published cover article. Name is the no neuron is added. That means the
2 minutes.
To brain function or the brain disorders is we must have this idea in the brain is a network, structure connectivity and function connectivity. So for this new concept, we must have the policy for treat the epilepsy. That means the repairing the spatial and temporal properties for the network and improve the therapeutic outcome. For this reason, we are established a new journal. It's named Brain Network Disorders with the Professor Miguel Nicolades. So we are actively seeking the submission and hope every experts in the room to support this new journal. So this is my conclusion. I want to use this Gardner-Hebb circle curve. It suggests even the scientists have long-term know about the neurons and the brain regions connect together. It's definitely basic research hot topic. But for the clinical view, we still don't have tools to bring these ideas to the bedside. So today I introduced this RNS and LITT. I think in the future, maybe it's can pick productivity, give our patients much more choice. And finally, I will show these pictures. This is China INI, and the background is our INI building. Thank you so much for Professor Sami. You are the father of the China INI and our mentor to supporting us continues. And Director Hongqi is in the room. We opened the China INI to 2018. So now each year we complete at least 10,000 cases each year. So thank you, Professor Sami. Thank you for your attention. Thank you.